Picture this. A healthy 30-something walks into the ER saying, "It's probably just the flu." 12 hours later, they're on life support. That overnight freefall is sepsis, an ordinary infection gone wildfire. The big question is, how do we stop that slide sooner and save more lives? Here's the good news. The 2024 Surviving Sepsis campaign guidelines just dropped, and they're the closest thing we have to a real-time GPS for clinicians. Today, we're going to unpack what's new, why it matters, and how you, yes you, on your next shift, can put it to work. First, a quick reality check. For years, sepsis care has been a mashup of solid science, educated guesswork, and because we've always done it this way. These new guidelines try to clean out that closet. They sift hundreds of trials, keep what truly saves lives, toss what doesn't, and turn the winners into step-by-step instructions you can actually follow at 2 a.m. Think of a chaotic control room finally getting clearer screens and louder alarms. Faster signals when infection is spiraling, sharper nudges on which antibiotic to reach for, better cues on when to pour in fluids, and when to pump the brakes. The very first signpost is recognition. Instead of hunting for one magic lab value, the guidelines say, layer your clues. A slightly faster breathing rate, a foggy mental status, a lactate that's nudging up, a blood pressure that needs just a hair more support. Stack 2 or 3 of those, and it's time to act. Hospitals are encouraged to build structured screening so the shaky patient at 10 a.m. doesn't become a code blue at 4. Now, let's talk antibiotics, because this is where the guidelines show their sharpest edge. Speed still matters, but the new mantra is fast and right. That means local antibiograms at your elbow, pre-built order sets, and pharmacy systems that flag when your first guess is probably off target. The goal? Make the correct choice the path of least resistance, not a riddle you solve in a crowded hallway. Next up, fluids and blood pressure. Old habit said, wide open the IV and pour it in. The 2024 version treats fluids like a dimmer switch, not an on-off light. Ask yourself, what am I trying to fix in the next 30 minutes? Use ultrasound of the heart and veins, do a quick passive leg raise, and reassess, often. When vasopressors enter the chat, pair them with realistic blood pressure goals and clear off-ramps for dialing back. Equally important, the task force calls out therapies that hang around mostly on hope, high-dose vitamin cocktails, routine immunomodulators, or those just-in-case add-ons with skimpy evidence. The tone isn't punishing, it's honest. If you leave the evidence path, say why, write it down, and don't let it distract from the basics that actually work. Here's a piece many guidelines forget: life after the ICU. Sepsis is a continuum that keeps rolling long after discharge. The update highlights screening for cognitive decline, PTSD, and new physical limits. In plain speech, that means a clinic checklist: memory, mood, exercise tolerance, meds, vaccines. Small, repeatable touches that turn mere survival into real recovery. Let's zoom out for a second. Think of the new guidance as tossing your paper map and firing up a GPS that updates every few minutes. A patient with pneumonia and kidney disease may get a very different route than a trauma patient with the same blood pressure, because the GPS knows the local traffic and the shortcuts. On the ground, sepsis care becomes a series of small, steady nudges. A nurse spots a subtle change in breathing and pages early. A pharmacist tweaks an antibiotic dose for obesity or renal clearance. A resident rechecks lactate after a modest fluid bolus instead of the automatic 1 more liter. None of these moves is glamorous, but together they turn a frantic scramble into something closer to instrument flying. Trust the data, adjust steadily, and don't overreact to every bump. Let that sink in for a second. Looking ahead, these updates invite hospitals to treat sepsis care like curating a playlist. You keep the core tracks: early recognition, right antibiotics, fluid finesse, but local teams remix with their own pathogens, resources, and staffing patterns. Soon, data from wearables, home blood pressure cuffs, even pharmacy refills could flag patients sliding toward danger days before an admission. The challenge, and the opportunity, is to plug those signals into a learning network so every treated case quietly improves the next. So, what does all this mean for you between now and your next shift? 1. Map out your first 60 minutes. Blood cultures, broad-spectrum antibiotics, targeted fluids. Where are you slowest or least confident? 2. Identify the early signals you and your team tend to miss. Maybe it's that low normal blood pressure or the patient who just seems off. Pick one concrete tweak, like adding a 2-minute neuro check to catch it sooner. 3. Finally, when the new recommendations clash with your habits, say backing off fluids earlier, picture a recent patient you'd handle differently today. Write down that scenario and keep it on your clipboard as a nudge. All right, time for our closing recap. Here's what we covered today. First, early recognition is a cocktail of small clues, not one magic number. Second, antibiotics must be both fast and right. Local data makes the difference. Third, fluids and vasopressors are a dimmer switch. Fine-tune, don't flood. Fourth, skip the shiny extras that lack proof. Double down on what works. And fifth, survival is just the halftime show. Plan for cognitive, emotional, and physical recovery after discharge. If you carry nothing else away, carry this. Sepsis care is moving from heroic rescue to reliable prevention. You've now got a real-time GPS. The sooner you start using it, the more lives and futures you'll protect. Thanks for listening. Next week, we'll dive into rapid diagnostics and how point-of-care PCR might shave precious minutes off that antibiotic clock. Until then, stay curious, stay prepared, and keep tuning that playlist for better care.